Hey everyone, welcome to my third video on glomerulonephropathies. In this video, I'll be talking about FSGS, or focal segmental glomerulosclerosis. So FSGS is a very complicated disorder. It doesn't describe the histological process or the disease process like most other glomerulonephropathies. This is because there are several histological processes found, and there are several different diseases, and a disease and a histological process does not necessarily correlate. Therefore, there are 6 different descriptions or forms of FSGS which are now described. FSGS is the second most common cause of nephrotic syndrome around the world. It's very common in adults relative to childhood, and it's an important differential up there with membranous nephropathy in any adult presenting with nephrotic syndrome. So, FSGS can be divided up into 6 main types, but the important thing is they all share a commonality, and that is, as seen in minimal change disease, effacement or fusion of podocyte foot processes, but there is also focal and segmental scarring of the glomeruli. Each of the 6 forms will have more specific histopathological findings, but it's too much to go through all of them, and it's not important for exams or for clinical practice in my view. There are 6 main types, 3 of them are common and 3 of them are uncommon. The 3 common types are made up of the primary or idiopathic FSGS. Then there is the APOL1 FSGS, and that's a genetic type. And then there's also adaptive FSGS. Those 3 common types make up the majority. You then have your 3 less common types. There's a genetic mediated FSGS, which is a much less common form of a genetic FSGS than APOL1, and it makes up over 30 different genetic predispositions. There's then the viral mediated FSGS, and finally there's the drug-induced FSGS. It's beyond the scope of this video to talk about every single type in depth because it's just not relevant to you or me clinically, and it's just far too complex, and this is really something for the renal doctors. In an exam, they may really focus on primary FSGS, although sometimes I wonder if the examiners even acknowledge that FSGS is more than just a primary type, and it's very presumptuous when you're answering a question whether or not they are talking about the primary type or FSGS generally, because FSGS you can't speak about generally. It's a heterogeneous group of disorders making up one, similar histological finding of glomerulosclerosis. So I'm going to talk a bit more about primary. Primary itself, otherwise known as idiopathic, I think it's probably better to say that it's just not defined by any of the other types, because one day we may not call it idiopathic or primary because we'll know what it's caused by. And that's the same for any idiopathic disease. We just don't know what causes it, and we assume that there isn't any secondary cause, but everything has a cause, doesn't it? And the hypothesis for what causes primary FSGS is a cytokine mediated one. We think that there is some sort of cytokine mediated damage to the glomeruli, and we know this because we've, for example, in one case gave a renal transplant to a patient with FSGS, and they actually developed a nephrotic syndrome. They did a biopsy and they found that it was primary FSGS. They then took that kidney away from the patient, they put it into another patient, just a diabetic patient, and the kidney was fine. It didn't progress in terms of its FSGS. The FSGS didn't recur. So the fact that primary FSGS can cause recurrent disease in a transplanted kidney suggested that it could have been something circulating in the body that was mediating this disorder. So the primary disease, it's a common form of FSGS in, young adults and adolescents, and it's a usually nephrotic range proteinuria, and sometimes it can be a massive proteinuria. The biopsy shows widespread foot process effacement, and these patients will often respond to steroids and or immunosuppressants like cyclophosphamide and cyclosporin, just like in minimal change disease. So yes, like I said, there is some overlap between these two diseases, and interestingly, they can both be treated the same as well. Just remember that the foot process effacement, the histological finding is the same in FSGS, i.e. primary FSGS, and minimal change disease, as is the treatment. And that's why we wonder if it's the same disease and FSGS is just a continuum of minimal change disease. The other forms of FSGS, however, are certainly different disease processes. I won't talk about them much because it's just beyond the scope of this video, as I've suggested, but I'll put up a nice table now just to show you an outline of what they all look like and how they present.
If you were to look at the table, you can see I've listed the 3 common types on the left. They're primary, adaptive, and APOL1. On the right side, I've listed the less common, which are genetic, infective inflammatory, and drug-induced. The infective inflammatory is essentially the viral type, but natural killer cell leukemia is also a described cause, so I've listed it here as infective inflammatory, but you can think of it as viral if you like. I've already discussed primary, so we'll skip past that. In the adaptive type, essentially, the body has a greater metabolic load than the kidneys can handle, so there's an increase in the glomerular filtration rate. This can be due to anything that will increase the metabolic load, such as cyanotic heart disease, sleep apnea, morbid obesity, even a high protein diet can do it. And people with low birth weight, if they're small for gestational age and they have a reduced renal mass, that will cause it as well. Chronic ureteric reflux, which often happens in childhood, is another cause. Because adaptive isn't really caused by an immune problem causing damage to the kidneys, it's more of a physical problem, one where there is too much filtration going through the glomeruli. So this one actually responds well to renin-angiotensin system antagonists, and this can halve proteinuria and prevent progression. The APOL1 variant of FSGS is essentially a genetic type of FSGS which occurs in people of sub-Saharan descent. It will cause a primary or adaptive FSGS picture histologically, and it will also respond to treatment as those two do as well. Essentially, it's just the genetic predisposition which causes a primary or adaptive type of FSGS. The genetic type of FSGS is different to APOL1 in that APOL1 is a specific genetic problem. The genetic type makes up over 30 different types of genetic predispositions, often with high penetrance. It's usually recessive, and there can be a family history of kidney disease. As there's so many types, it varies in how it presents, and it's usually unresponsive to immunosuppression. But again, this type of FSGS is so heterogeneous in its forms, so not much can be said about it. The infective and inflammatory type of FSGS, or the viral type, is usually caused by HIV. It can also be caused by CMV, parvovirus B19, and natural killer cell leukemia, but is more popularly asked in questions in exams as an HIV-associated disease. You should treat the underlying cause, for example, if a patient has HIV, with highly active antiretroviral treatment. And lastly, there is drug-induced. And drug-induced is usually caused by things like heroin, lithium, and bisphosphonates. If in an exam you have a question where they ask you about a patient with worsening renal function or a glomerular nephropathy, and they're a heroin user, or they have HIV, or maybe just hypertension or obesity, they're probably asking you about FSGS. If they use a young Afro-Caribbean male, they're usually talking about FSGS as well. This is because Afro-Caribbean people make up a large proportion of FSGS patients due to the APOL1 variation, but just a general genetic predisposition to getting FSGS and a genetic predisposition to having some of the really more severe and sinister causes of FSGS. This would include collapsing glomerulonephropathy. Do read the question and try and answer it properly, because you never know, the examiners may try and trick you, but from my experience, they tend to ask it in quite a stereotypical way, often with a young black male. Another popular question in exams is a patient with worsening renal function, potentially young, potentially with a family history of worsening renal function, and they may have yellow dots on their eyes, or they may have hearing loss. And a hearing loss is often the giveaway. This is a patient with Alport syndrome, and Alport syndrome is rarely, but can be described to cause FSGS as well. And this is surprisingly popular in exams, given how rare it actually is in reality.
A variant of FSGS is called a collapsing glomerulonephropathy, and this causes a segmental and global collapse of the glomerular capillaries with, marked hypertrophy and proliferation of podocytes, and it causes severe tubulointerstitial damage. This is a really rapidly progressive, really awful form of a glomerulonephropathy that is heavily associated with HIV and African ancestry. So you have to have HIV to have it, but for some reason it seems to affect people of African ancestry far more commonly than anyone else, and therefore we think that there is some sort of genetic predisposition to having this form of glomerulonephropathy. It needs aggressive treatment, and that will require steroids and cyclophosphamide as with any other aggressive glomerulonephropathy, and this is something that could come up in your exam as well. If you have a question with a patient that has a rapidly progressing glomerulonephropathy and they have HIV, they're usually asking you to tell them that you know about collapsing glomerulonephropathy. FSGS is a progressive glomerulonephropathy. Half of patients, unfortunately, will progress to end-stage renal failure despite treatment. Treatment is essentially with steroids, much like with minimal change disease. Patients, however, who don't respond to steroids, or they have a relapsing disease, can receive cyclophosphamide or cyclosporin and tacrolimus, and occasionally mycophenolate if they're intolerant, which is the same as minimal change disease. So, to summarise, or just tell me what I need to know for my bloody exam, will you? Essentially, FSGS is a heterogeneous group of disorders made up of 6 forms, which are characterized by their clinical presentation, histopathological findings, and disease processes. Primary is the commoner type, making up 20 to 30% of cases, usually happens in younger adults and teenagers, presents with nephrotic range proteinuria and responds to steroids and potentially calcineurin inhibitors such as cyclosporin. There are also other causes which would include HIV, Alport syndrome, other infections such as hepatitis B and C, and it can also be due to heroin use. One of the subtypes of FSGS is collapsing glomerulonephropathy, which is very rapidly progressive and requires aggressive treatment with cyclophosphamide and steroids. So that's FSGS in a nutshell. I think because it's so complicated, I've distilled it into such a small, simplified form that actually it becomes quite straightforward, I like to think. Just remember for your exam, if they're asking you about a younger patient, maybe they're of an Afro-Caribbean descent, maybe they have HIV or heroin use or Alport syndrome, they're asking you about FSGS. That's just how they classically ask, just as though if you had a brown patient with a cough or night sweats, they have tuberculosis. Or if you had a gay gentleman who came in with weight loss and frequent infections, they have HIV. Unfortunately, the exam boards haven't caught up with political correctness or just, real life. but that's just how they write the exams. Everything is stereotypical and presents in a certain way, and you can use that to your advantage to learn and pass an exam. So thanks for watching my video. I hope you didn't find it too grueling. And just remember, you know, the reason I'm doing this is just to take a really complex subject and try and make it digestible to anyone, i.e., medical students and doctors. I'm not necessarily expecting you to learn all of this, but if you were to try and go and read about this yourself, if you really wanted to, it's a really long, difficult subject. So I'm trying to do all of that hard work for you. And it's all there if you ever wanted to learn about this subject properly. All the information, I've digested it and I'm giving it to you in an easy to understand format, I hope anyway. So thanks for tuning in, and I'll see you for the next video where we'll finish off the non-proliferative glomerulonephropathies. Yes, we're only a quarter of the way there, could you believe it? Only a quarter. Please just take some time to have a quick look at the references as well for this video, which you will see now.